Okay, ladies and gentlemen, dear chairs, it's a great opportunity for me to talk in here. And after talking with some key person from developed countries, one person from developing countries going to talk about something about evidence-based medicine. My name is Sakineh Hajebrahimi. I'm a professor of urology, and my fellowship is female urology and neurourology, and this is my main job in my hospital. And in addition, I founded 16 years ago the first Iranian Center for Evidence-Based Medicine, and I'm working in the center as well. Here is my university in the northwest of Iran. It's Tabriz University of Medical Science. And my center is in the university, the Faculty of Medicine. And this is my hospital. This is the main referral general hospital in the northwest of Iran. And we have lots of referral patients in our department. And this is our main partner for JBI as well. Our center is one of the JBI affiliated group from last year, and we have lots of activities in our centers as well. The key point of my center is I have a huge amount of young population in my center. And any of the students in my center are a teacher at the same time. And each of the students should teach 5 other students in the center. So we have huge amount of students in our center, and they are helping us to do the systematic reviews, guideline adoption, not development, and in addition, the other activities regarding implementations. So it is all about a developing country, and we are going to our disclosure. I have nothing to disclose, it's clear. And my talk today is about the prostate cancer screening. And working 16 years in a evidence-based center as a clinician actually taught me to be very, very simple. So I try my best to be very simple to explain some methodological aspect about the screening of prostate cancer, and its name as a smart screening of prostate cancer. Prostate cancer accounts for approximately 26,000 deaths in the United States in 2017. And currently, even in age-adjusted mortality of 90% for 100,000 men is a 50% improvement compared with early 1990. Still too much. And autopsies studies have identified prostate cancer in approximately 5% of specimen for men younger than 30 and for 60% younger than 79. So it seems to be very common. And for the common disease, we have 2 solutions: early diagnosis or screening. If there is no sign and symptom, so you have to go to a screening. And if you have some special sign and symptom, you can directly go to the early diagnosis. So for prostate cancer, we need to have some strategies for screening. What is the best strategy? One of the best strategies that's defined in 1992 was PSA or prostate-specific antigen. I'm not going to deep of the history because there are lots of controversies about the position of the PSA for screening of prostate cancer. But just imagine, okay, this is a good tool, non-expensive, and just very accessible and accessible to do a screening for prostate cancer. And if you compare 1990 with after 1992, you can see the rate of the advanced disease decreased, but the rate of radical surgeries for new diagnosed patients because of increasing the incidence of the prostate cancer increased. Just put in your mind, increasing the radical treatment, increasing the incidence at the same time, but before there was some increasing in advanced disease, okay? So, prostate, some factors affected PSA, like age, prostate size, and some medications as well. And when we are screening with PSA, we have to think about all these factors that affecting PSA. So, if you want to calculate the accuracy of the PSA, you can see a sensitivity is around 79, a specificity 59, and positive predictive value of 14, and negative predictive value of 89, and overall accuracy of 64. I would like to ask one of the students, what is the meaning of these numbers? Or young population, young participants. Do you know what is the meaning of this kind of person and the numbering in here? No? I know you all know about that. Okay, you can see, even after doing such a good screening, still we have some false positive, false negative, and still there is some patient who have test positive, but they're not patient, or test negative, but they are still patient. Oh, okay, this is one arm of our problem when we are talking about the PSA screening, and we have another main concern about overdiagnosis and overtreatment. Just remember, overdiagnosis is not the false positive. False positive is falsely without this patient, this person is patient or has cancer. But when we are talking about diagnosis, overdiagnosis, the patient has a small problem, but this problem may not make any harm for him or during a natural life. Okay, so you can just call a person as a cancer person, but he can live like the other people that have no experience of cancer. Let me explain more, because this part is very important for us to make a decision. Imagine, is it working like this?
Yeah, it should. Just press it.
Okay. Okay. Imagine we have two kinds of population, one who is screened with PSA and the other one not screened. During this two population, 76 of non-screened one has prostate cancer and 88 of screened one. And from both of them, 7 died because of prostate cancer, okay? And then 61 survived, with prostate cancer were appropriate treatments. And from here, 81 just survived. Okay, what is this subtraction of this difference of 20? Sorry, this is some patient who overdiagnosed. That means the cancer never make any harm for them, even if they live for a long term, like 20 years, 30 years, and something like that. So we overdiagnosed 20 people, and we call them, you have cancer, and they just psychologically deal with this problem over the life. So, what's happened after overdiagnosis? Overtreatments coming just after overdiagnosis. And if you overtreat, I mean doing a radical surgery for such patients, so the patient may have some surgical complication. Even before any surgical complication, even if we just do a biopsy for those patients, the patient can have infection and risk of some big complication and other risks. So having those overtreatments and overdiagnosis, we should have some good strategies for screening of patients with prostate cancer. For this reason, two different randomized control studies defined in the US and Europe at almost the same time. And this study was done in the US. I don't want to explain everything about these studies, but there was some people who randomized to screen and not screening and having the usual care in US for those patients. And what was the result after 13 years? During the 13 years follow-up, they found that there is no difference between the mortality rate of screened and non-screened people populations. So the screening by PSA could not reduce the mortality rate between the screened and non-screened group or control group. And immediately, U.S. task force decided to decline any kind of screening of prostate cancer in all U.S. Very, very direct decision. But after that, they found this study had some problem. And this study is contaminated. And they report the rate of 40% contamination in the study. That means some control group going to the screen group, or the control group already screened during their life. So, but even with a very careful, critical appraisal of this study, you can find maybe more contamination, like until 90% of contamination. Thank you. Sorry for my voice because of cold. Thank you. How about the other study that have done in Europe? They have done almost a similar study and compare control group and screen group as well. And they said our contamination rate is much more lower than US one. And then they found that after 11 years of follow-up, they found 21% reducing immortality rate of the patient in screening group comparing with control group. So they continue their evaluation. The first report was 9 years, and then 11, and then 13 years. And this is the final report that's for reduction of 21st person in mortality rate. And if you take a look in here, you can see in the 9 years follow-up, the number needed to screen was 1410, and number needed to treat to survive one person from the prostate cancer was 48, and it's reduced when you increase the follow-up years to 781 and 27. And that means if you treat 27 patients with prostate cancer, you can save one. So it's a very great clinical decision-making about those patients doing a screening or not doing the screening at the same time. So, this study believed that because of low contamination rate, that it was around less than 40%, and we can have more trust to this study than the US study. But still, even in this group, part of the control group during the medication or treatment for prostate cancer got appropriate treatments, and we have some problem in contamination during the treatment phase. So the contamination rate for this study was between 23 to 40. So what can we conclude from those studies? It's just controversies goes on, and we can't conclude completely, but we can say there is no place for mass screening of prostate cancer in general population. And the other thing we can conclude is not to do any kind of screening for the people over 75 years, according to this data. But still, we don't know what can we do for the other people who are in the risk of prostate cancer. Okay. During the several studies for our overdiagnosis in the US, you can see the rate of overdiagnosis between 22 to 42. Still, there is lots of overdiagnosis, and it's estimated that when the age is older, the association between overdiagnosis and the screening is higher. But when the screening interval increased, the overdiagnosis decreased. So some people came to brought some modeling, and they added some risk factors that can affect the PSA. And they said, okay, the rate of PSA is like this, and we can add age, size, and race, everything. And then regarding this modeling, we can just have some proportion about the cancer for this patient. But the problem is no screening strategy can estimate the problem of overestimation, overdiagnosis. And in addition, even by having several modeling systems, we don't have any evidence regarding the efficacy of those modeling systems. So we should have some prevention strategies for like the overtreatment preventions, like active surveillance, or adding some new biomarkers, or adding MR to our diagnostic. And there is several strategies. I don't want to take your times for that. Yeah, that's clear. But again, we need to focus on the psychological effect of cancer on a person who diagnosed by cancer and the financial effect of those to the health system. So again, in U.S. task force decided to have some short recommendation regarding the screening, and they said, okay, we don't need to do any screening for any patient who have no life expectancy more than 10 to 15 years old. That's great. And for anyone for less than 40, that's great again. But we should have a good shared decision making between people between 15 to 65 to do or not to do the PSA screening, with explaining the benefit and harm of the PSA screening for all of those patients. And imagine the level of evidences that I explained to you cannot be more than 3. But for some of this recommendation that I will show later, you can see even A grade of recommendation, and you can see the effect of expert opinion during writing the guidelines. Anyway, after long way, you can see only grade C of recommendation in here and grade D of recommendation in here. And this is the European guideline for screening the prostate cancer that just published. And you can see the same conclusion for this part, but they have a detailed conclusion about the patient who are on risk of prostate cancer, and they recommend to do some screening for the high-risk patient, but again with having shared decision making for those patients. Again, you can see the level of evidences and grade of recommendations in here, and you can compare the level of evidence and grade of recommendation for those patients. If you're asking me, what can we do? I don't know. But again, I believe we should have a good shared decision-making with our patient, and we have to explain the benefit and harm of the screening for the patient who are in the risk of prostate cancer. This is the meaning of smart screening of prostate cancer. Anyway, even with having the low-stage prostate cancer, if you go to the Tabriz Bazaar and buy a beautiful carpet from the capital of carpet in the world, you will be free of cancer, I'm sure. Thank you very much.
Thank you, Sakineh. It was really brilliant, and I have to highlight that one of our partners of this symposium is Nadation Men Against Cancer. So we will have also some more information about the prostate cancer during the day from Professor Babiuk. And we have here also some colleagues who are working on the project about the screenings in the Czech Republic. So I do hope they would like to ask you something. So I'm opening the discussion. Do you? Okay. This is what I expected.
Thank you very much for your very instructive presentation, but I would like to ask a different thing, because this is a very good summary of evidence, but maybe implementation is a different thing, because in fact I think in Czech Republic, but it will be more prevalent in other countries also, there is a big number of opportunistic screening ongoing. So the question is, at these circumstances, should we somehow promote organization of screening or organization of the care? Of course, bearing in mind all your recommendation, let's say from your final slide, or should we, let's say, leave the situation as it is? Because the point is that it will happen anyway. So the question for the decision maker is now: should we do at least some organization of the preventive care, or should we just do not care? Thank you very much.
It's a very difficult question to answer, but I think any intervention in the in this issue, because it's cancer, and to many of people just scaring to have cancer, talking about cancer. Any change and any intervention should be done very, very slowly. Okay, and I'm not just optimistic to have a very radical, interventions to say no, there is no screening is needed, or no surgery, nothing else. But we need to prepare the environment for some new changes, and we should have good advertisement and good, kind of recommendation for the population. I think is that. Okay.